I don't know. So, but now the only thing we'll use it for is really post-op shivering in patients in the hospital. If they have shivering after anesthesia, we'll give them Demerol. They're classified for pharmacologic effect. There are pure agonists, fentanyl, morphine, and meperidine or Demerol. There are also partial agonists, antagonists, and nalbuphine, butorphanol, and pentazocine, or Pollen. So I can never figure out these. When some people use these, and I can never really figure out when they would be better than using a pure agonist. So I don't have any experience in using these. I can never figure out how that works. If one's an agonist, the other one's an antagonist, you're kind of defeating your whole purpose. But it's what you're trained on. And then we have the antagonists, which are Naloxone, which is Narcan, and Nalmethine, which is Revex, which I'll talk about briefly. So Narcan is a pure opioid antagonist. It acts on all the receptors to displace the opioid. So it has the greatest affinity for mu receptors. It does reverse most effects of opioids: analgesia, sedation, respiratory depression, hypotension. So it will help to reverse all those effects. It does not reverse and may cause nausea and vomiting. So if you do give this, you could possibly precipitate an emesis or nausea with it. And it's not addictive. Generally given IM, you can give Narcan intravenously, IM, or subcutaneously. All these are acceptable. Generally 0.4 milligrams, repeat up to every 2 to 3 minutes, up to 4 times. Children 0.01 milligram per kilogram with subsequent repeat dose generally every 2 to 3 minutes as needed. Indications: emergency drug or unexpected life-threatening respiratory depression. So this is the person that they pick up off the street that has the heroin overdose. And you can give this intranasal also. And I just wanted to show this. They have this nasal atomizer that you can actually, and they have a vial, these preloaded vials of Narcan. And when somebody comes in off the street, a lot of these patients are heroin users. They don't have veins, so how do they give the Narcan? They give it through a nasal spray. So something to think about. These are probably pretty cheap, but you just put it into the syringe and you put the plunger on, press the plunger, comes out through the atomizer, through the nose, and it's rapidly absorbed through the nasal mucosa. So this might be something to think about if you versus giving it sublingual or so just another way to give it. So it should be titrated according to the patient response. Can be given IV. Obviously, IV is going to work quicker. You can give it IM or sub-Q, dosing approximately 1 microgram per kilogram. Again, we talked about the doses. So again, you generally want to titrate it in. You don't want to just push in a large amount of that. So ideal reversal, the patient would be adequately alert. Respiratory status would be the patient can breathe on their own, no significant pain or discomfort. We don't want to reverse all of the narcotic because then you can precipitate pain for the patient. That can be problematic. So do not overdose the Naloxone to prevent complete reversal of analgesia. You can get undesirable hypertension with that, tachycardias. You can also induce nausea and vomiting, so that can be problematic. Competitive antagonism can be overcome by administration of additional opioids. So you can give the patient additional fentanyl or whatever you want, and you will displace the Naloxone. It's metabolized through the liver. Repeat dosing may be required within 1 to 2 hour intervals if sedation or respiratory depression reoccurs. Elimination half-life 30 to 81 minutes, meaning somewhere around 60 minutes. So both flumazenil and Narcan, about 60 minutes for the elimination half-life. You can give it IM, and you can repeat the dose to prevent resedation. Some undesirable effects that we talked about: cardiorespiratory effects, often no prior history of cardiovascular respiratory depression. So you can get this tachycardia, unmasking severe pain and physical dependence. You could put somebody into withdrawal with it, so you have to be careful about that. Again, not everybody tells you that they're taking illicit narcotics. It's generally a CNS stimulant effect. You can get this sudden dramatic increase in circulating catecholamines, so we get this surge of catecholamines in the central nervous system. And we get endogenous reversal of endogenous opioids or endorphin, which is the natural occurring morphine compound in enkephalins. So if we reverse these, again, these can precipitate immediate pain or withdrawal in patients. Other issues: hypertension, hypotension, tachycardia, arrhythmias, including ventricular tachycardia and fibrillation, cardiac arrest. And these are often in patients with cardiovascular disease who are taking cardiovascular medications for hypertension. or anti-anginals and things like that. So we have to be careful if we do reverse somebody with cardiovascular disease. Pulmonary, they talk about acute pulmonary edema with this, so you could precipitate somebody into acute pulmonary edema, which could be problematic for the patient. And they think that when we reverse somebody, we get increased central catecholamine release, which causes vasoconstriction. We increase the amount of fluid in the vascular system and compress the vascular system, which pushes hydrostatically fluid into the lungs, and it can precipitate acute pulmonary edema where you get that pink frothy sputum in somebody if you do reverse them. So you have to be aware of that. Other events, cardiovascular, pulmonary events often in patients with cardiovascular disease or taking cardiovascular medications, CNS anxiety and seizures, gastrointestinal we'll talk about, nausea and vomiting, and then blurred vision and other things like that. The other thing that we talked about briefly is that acute opioid withdrawal in patients, so we have to be careful. Again, not everybody tells you that you're using illicit narcotics, and you can see nausea and vomiting, increased heart rate, hypertension, sweating, trembling, anxiety, irritability, runny nose, seizures, things like that. So you can precipitate acute withdrawal in patients taking chronic narcotic medications. This nalmefene or Revex, it's an interesting drug. I just put it in here because it's a pure opioid antagonist. Longer duration of half-life than Naloxone. The half-life is 10 hours. So I'm thinking, why don't we use this drug here? This is great. It's not available in the United States. So the FDA has not approved it. So another drug, the FDA, for whatever reason, we cannot get it approved here. I'm sure there's some reason why they didn't do it, but and then the other issue becomes to do studies on these drugs, you have to subject humans to it, you have to put them through trials, and if there's any adverse outcomes, somebody's going to get legal action. So some of the drug companies don't even bother with it. But it would be nice because it has that 10-hour half-life. So again, the chance to need to redose the patient would be non-existent almost. So it would be a great drug, but it's not available here. So thanks to the FDA. And just throw in Suboxone. A lot of people on Suboxone today. And what is Suboxone? I never really fully understood how this worked, but it's buprenorphine, so it's one of those agonist-antagonists, and Naloxone. So I was thinking, well, you have an agonist-antagonist with the buprenorphine, and then you add Naloxone to that. So how does it work? So it's an indication for chronic morphine, heroin, or oxycodone addiction. So there's a lot of patients out there taking Suboxone. When you drive by roads, you see Suboxone clinic, and you see a number on one of those portable signs, at least where we live in Pittsburgh. So they're always looking for patients to put on Suboxone. So buprenorphine is an opiate partial agonist, and it acts as the opiate substitute to alleviate withdrawal symptoms. So actually the buprenorphine is actually active, and the Naloxone is not absorbed sublingually. So this is a sublingual film, and it's dissolved in 48 minutes underneath the tongue. So the Naloxone is not actually active in this drug combination. So why did they put the Naloxone in? So that illicit drug users will not crush the pill and inject it. That's why they put it in there. So I just wanted to cover that. Does have also Naloxone in it, the Suboxone. But so that's so they don't heat it up on a spoon, draw it up in a syringe, and inject it. So if they illicitly get Suboxone. So opioid reversal should only be used when necessary. Titrate to effect where sedation, respiratory depression are reversed, and tolerable pain. So we don't want to reverse all the natural endorphins and all the pain, have the patient kind of precipitate a withdrawal type reaction. The other thing is that one of the things that we can do is use other methods of non-opioid pain control. So adequate local anesthesia, so using bupivacaine or Marcaine for long-acting local. NSAIDs pre-op, you can use ibuprofen, you can inject ketorolac intravenously, or Toradol. I give a lot of patients ketorolac, and it works very well. It decreases the narcotic use in patients, so that's a good thing. And now a lot of patients in the hospital are using this ofurmative or this intravenous acetaminophen, and they claim that it reduces their narcotic use post-op. So this drug is expensive because it's a fairly new drug, but when you do cases in the hospital, they're giving everybody pretty much this, unless they have liver disease or hepatitis, this ofurmative or this intravenous acetaminophen. This was the cost I was talking about. So flumazenil, this was the guy who was reversing everybody. So he's running up the $25 bill per patient until his partner found out, and went from being the greatest thing to the worst thing. So, for a 5 cc vial, $24, 10 cc vial, $37. So somewhere, $25, $28 range. Naloxone, not cheap either. 0.4 milligrams in a 1 cc vial, $14. If you get it in a preloaded syringe, 2 cc syringe, $29. So the vials are cheaper. So again, another reason, only use it if you need to. I did want to put in something called Sugammadex, just for completeness and reversal agents. And this is it's a modified cyclodextrin. It's for selective muscle relaxant binding agent. So if somebody is treated with a steroidal type of muscle relaxant like rocuronium or vecuronium, you can actually reverse the effects of that. And the big benefit would be, if you look at this cyclic molecule, so it actually kind of binds the rocuronium in the central aspect of the molecule, and it decreases the amount, allows acetylcholine to actually act and transmit through the muscle. So it reverses muscle relaxation. So what's the benefit of this? So it encapsulates unbound rocuronium to a lesser extent vecuronium, which are steroidal type of neuromuscular blocking agents, and it reduces free neuroblocking agent drug fraction as a neuromuscular junction, and it reverses rocuronium and vecuronium-induced muscle blockade. So what would be the benefit of this is that we could use rocuronium and vecuronium if somebody had a medical emergency in the office. We wouldn't have to give them succinylcholine. So what's the benefit of not giving succinylcholine? Obviously, succinylcholine is a malignant hyperthermia trigger. So that would be the benefit of this. So again, most balanced anesthetic techniques, again, what they're using is, again, narcotic benzodiazepines, and they're also using neuromuscular blocking agents and also inhalation agents. So we get paralysis with that, and it's easier surgical access. You can ventilate the patient better. So we use the immediate non-polarizing agents, rocuronium and vecuronium, or cisatripurium, and they're short-acting. So, but they can act up for up to 30, 40 minutes. So if you would use those in the office, the problem is you'd have to ventilate somebody with an ambu-bag for 30 to 40 minutes. So if you did that, you could reverse it with this Sugammadex. So succinylcholine, again, most widely used. Onset is 1 minute. Duration of action is about approximately 9 minutes. So we can definitely ventilate somebody for 9 minutes. But when you start getting 20 to 40 minutes, that becomes problematic with that. So again. The big problem is that, again, not available in the United States, available in Europe, but not in the U.S. So just another one. So useful addition to reversal agents in anesthetic praxis. It inactivates rocuronium, has a high affinity for vecuronium, no clinical relevant effects on cardiovascular system or hemodynamic system, no metabolism excreted in the urine. Generally well tolerated. Few adverse events. The adverse events were generally mild. Common things, procedural pain. Uncommon thing, the big reason they didn't do it is that you can get bronchospasm, prolonged PT, hypotension. So this is why it hasn't been approved in the United States. So it would prevent the need to use succinylcholine, which is a potential MH trigger for routine emergency intubation. So if everybody has succinylcholine in their office, could switch to these steroidal type of neuromuscular blockers. And then limits the need to potentially ventilate the patient for prolonged periods of time following emergency use of non-depolarizing muscle relaxants like rocuronium. So it will give us another margin of safety, but not beneficial here. They're supposedly revisiting this, so hopefully this will be available in the near future. Although Ed talked to somebody who said they're not going to approve it, and I was online the other day and they said it's close to approval, so I don't know what the right answer is. So hopefully they will someday. And then we would not have to keep succinylcholine in the office. And potential MH trigger, so that's the big deal with Sugammadex. So post-reversal care, reverse only if necessary. The patient should be maintained with continuous monitoring. So again, if we do reverse somebody, you have to monitor that patient. Oxygen and emergency resuscitation equipment should be available. Post-anesthesia care personnel should be skilled in the early detection of hypoventilation, airway maintenance, and ventilatory support. And the big question is, how long do you monitor somebody if you do reverse them? So you should monitor them for a more extended period of time. And what that time is actually depends on how much initial drug you gave the patient, the response of the patients to the benzodiazepine or narcotic initially. So again, I think you're probably looking at really probably having that patient in the office for about 2 hours or if not longer. So that can be problematic. And if you do reverse somebody, I don't think it's a good idea to put them in the recovery room, put the monitor on, and have the parent watching them. I think you'd have to have one of your staff people in there if you do reverse somebody. So manpower becomes an issue. So thank you.